Hey guys, welcome to the How to DSI video. We're going to begin with a patient, total stranger by the way, and we're going to start off from the initial arrival all the way through to the successful DSI.
O2 stats 95, BP 140 over 80. This is our second nab that we're giving him. His heart rate is... Are you feeling any better after breathing treatment? I'm a little worried about him. He's not getting any better. He's a little agitated from the hypoxia, and he barely keeps the mask on, so he definitely won't take a CPAP. Agreed.
What's going on, guys?
Hey. We got a 50-year-old male. He came in here, respiratory distress and tripod position.
Okay.
Gave him a neb. He seemed a little agitated. This is the second neb, so we didn't give him a CPAP. His SpO2 was 95%. Blood pressure 140 over 80. Heart rate 100.
Okay. I'm gonna listen to you breathe, okay? He's closed up pretty tight. All right, let's go ahead and get him moved over. 1, 2, 3. Keep that on your face, sir. You're doing a great job.
So as we get into this, guys, I want to thank Scott for playing our patient. We're going to now transform him into a sim man for the rest of the process.
All right, so he wouldn't tolerate the CPAP due to agitation. He's losing tone, going into respiratory failure.
The medic, having seen this, alerts his team, and he states his plan to continue under the new DSI protocol.
Let's move towards DSI. LT, if you'll watch SpO2, we need to make sure we stay above 94%.
So the crew will begin by first prioritizing initiating treatment of those unstable vital signs, namely hypoxia first and second hypotension. We're also going to establish full monitoring because that's required to do DSI successfully. And someone is also going to begin working on establishing a kit dump. You'll notice that they're all doing this from memory at this point in time, and that's okay. The intubation checklist actually works better, and it actually helps with continuity of completion of the checklist if we do it during a timeout before we actually intend to push paralytics. There's just a lot of task load going on right now for everybody, and so doing the checklist in one continuous run towards the period when we're actually going to intubate and actually we've started the treatment process is a little better, a little more fluid. Also, don't begin DSI with the patient supine. In this scenario, the patient was in full Fowler's, but you'll notice that they lowered the patient down to 30 degrees. This will be important for getting the best pre-oxygenation that we can.
And I'm going to lower the head to 30 degrees.
And we need to use ear to sternal notch position, which is not achieved by lifting the head of the bed to 30 degrees alone. And so what we're going to do is assess our patient, look at the ear canal, and raise that to above the top of the level of the sternum. Ear to sternal notch, the way we do it matters. So if the patient has any extra body tissue, fat, muscle, whatever, we need to pat underneath the shoulders to line the torso up before we pat under the head as well.
And let's get high flow.
And to pre-ox effectively, we're going to provide a high flow nasal cannula or flush rate nasal cannula underneath the BVM that you'll see us use momentarily. We will swap the device out from a capno to a standard nasal cannula. And then we will hook the regulator up and turn it all the way up to the maximum. This is for a brief period of time, so it is not unbearable to the patient.
Here's your BVM. Reset your PEEP to high, switch.
Next step in the pre-oxygenation process, we will use a max BVM setup, which includes a PEEP valve attachment and a tight face mask seal, and we'll hold that for both breathing and apneic patients. You may be wondering, why intubate a patient who's still breathing? Why not just take them to the hospital? The need for intubation is based on multiple factors, airway protection being among the most important. When a patient has a severe enough failure in this category, we must intervene or the patient can face serious complications. That's why you might see a patient who is not only still breathing, but may even be breathing adequately receiving DSI. To pre-oxygenate a spontaneously breathing patient, all that's required is your max BVM bag with a PEEP valve attached, and of course your high flow nasal cannula underneath, and you just hold a tight mask seal and allow them to breathe through the bag. And for our apneic and hypoventilating patients, all of the same applies. However, we will squeeze the bag once every 5 to 6 seconds and adjust PEEP as necessary to maintain oxygen sats. We will also change from traditional EC grip over to the thenar grip, which you see shown here, thumbs pointed down towards the patient's feet, all the rest of the fingers behind the angle of the jaw. Also, if you happen to be running the bag, this guy looks like he's trying to get some air, like hang time literally, off the patient's face. We're going to switch from 2-hand bag squeeze over to 1-hand squeeze to make sure that we don't inflate the gut and cause a vomit volcano.
Okay. I think it's all gone. I think
Let's make sure we use 2-handed thenar grip. So you'll slide around behind his head there. Do you need the head to come down some? No. Okay. Let's just make sure the thumbs are pointed down towards the chin, and the heels of your hands are kind of right here. And then middle finger behind the corner of the jaw.
Kit dump should be most of the way completed at this point in time. Go ahead and place the tube tamer under the neck and our bougie ET tube and tested suction under the right shoulder. Also not a bad idea to go ahead and draw up medications to be administered. And lastly, don't forget to turn on that VL scope and make sure it's recording.
All right, we've already determined that this gentleman is 220 pounds. So that's going to be 100 kilos. It's going to get 200 of ketamine.
In line with that, we should give ketamine early. Delayed sequence intubation actually has us giving it much earlier than we normally would for RSI. We want to do that so that the patient's more compliant for our pre-oxygenation efforts.
I'm going to go ahead and give our ketamine.
So medics give that early. It's actually also part of the criteria to start our 3 minutes of pre-oxygenation. So we have to give ketamine, have a max BVM in place, and have a SATA 94 for 3 full minutes before we can give rocuronium. So you want to do that pretty quick in the process.
I'm going to set the timer to 3 minutes.
We also have to have a systolic above 100 to initiate the administration of paralytics. To do that, you want to be aggressive about managing your patient as possible, and for situations where time is a factor, if you're delayed getting your hypotension protocol fully implemented, get that push dose epi on board as a bridge over so that you can get time to give your fluids or up your dose of vasopressors. Also, avoid rookie mistakes. Don't leave your monitor behind the head of the stretcher. Nobody can see it there. Move it to one of the mounting locations on the ambulance, or what I like even better, down by the foot of the stretcher. Just put it on that pull handle that's between the patient's legs. Just be careful not to pinch the patient. That's down where everybody's looking anyway, and you'll have the best visibility there. Additionally, make sure your pulse ox probe is on the opposite arm of your blood pressure cuff. We're going to also increase our blood pressure frequency to every 2 minutes.
You still working on kit dump?
Affirmative. I just need to test the suction unit and verify I have all the suction equipment out and ready.
Okay.
So now you'll notice the activity in the back of the truck has died down, and that's because we've gotten all our tasks done and we've optimized all critical skills. So now is the time to initiate use of the checklist.
All right. I'm going to run the checklist.
Here's the DSI intubation checklist. It should be used on all intubations, regardless of crew configuration or number of providers. It is everyone on scene's responsibility not only to participate in the completion of the checklist, but also to prompt the team when the checklist has not been initiated. Now the lead medic will go through the plan portion of the checklist. He's doing it with himself in this scenario. However, best practice would be to have someone who is hands-off in patient care serve as the checklist lead to allow all other providers to serve and focus on their primary roles.
So our plan, primary is going to be an ET tube. Backup is going to be BVM and supraglottic. Crank if we end up in a COCB with no successful king.
The remainder of the checklist should be completed in a call and response fashion, meaning when the person running the checklist calls for an item, another crew member should verify it. The person holding the checklist should not verify it. This builds teamwork on the scene and makes sure that we are all working cohesively. When an item is missed, the entire group will pause, wait for it to be completed, and then move forward together.
Pre-oxygenation. We have high flow nasal cannula at max setting.
Sure.
Urinospermal notch.
Yes.
Head of bed 30 degrees.
Yes.
Heap of 5.
Yes.
And max BPM in progress.
So, perfect example at the very end there of how not to run the entire checklist. Now, is it a big deal in this situation? The checklist lead checked off the BVM was there himself. and nobody responded to them. We've already checked a lot of things related to the BVM. It's obvious here. However, if we were to run the entire checklist in this fashion, then we would defeat the purpose of using a checklist altogether. So we want to do that call and response as you just saw. One person to say something, another person to check it, and it's as simple as that. The team will proceed on through the checklist doing the monitoring section, the kit dump section, and the med section. If they come across any bullet that isn't complete during this check, then they're all going to stop, get it completed, and then move forward together as a team once again. Now we're at our goals section. So, as mentioned previously, ketamine is part of pre-oxygenation. So, when you give your ketamine, if your oxygen sat is at 94% and you have a max BVM on the face, you can go ahead and start your clock then. If 3 minutes hasn't elapsed at this point in time, you have to wait until that time has elapsed.
You have a systolic pressure of 100 or greater.
110 over 70.
And SpO2 right now?
96.
All right, 3 minutes is up.
Now that we've covered all the basics of your training, it's time for the moment you've been waiting for.
Giving the paralytic.
Lock is in.
Lock in.
15, 13.
Hopefully that was all you expected it to be, since we have not utilized paralytics up to this time in the system. However, you must hold your horses. We have to set a timer for 90 seconds and wait that full duration before we proceed with intubation to ensure that the patient is fully paralyzed. So, utilizing the perform section of the intubation checklist, we want to ensure that the checklist gets us all the way through the preparation to the post-intubation management. So somebody needs to have hands on this checklist and be utilizing it throughout the entire process.
150 milligrams. Starting the 90-second timer.
Next, the team will coordinate the intubation attempt itself. So what you'll see is the medic advises the lieutenant on scene that he will serve in the role as the monitor watcher. And while that is very important, all present on the scene should be vigilant, with the possible exception of the person doing the airway assistant role, to warn the medic when a bailout is needed because the SAT has dropped to 94%.
All right, as we get ready to intubate, LT, I'm going to have you keep watching that SpO2. If we get to 94%, call bailout. If we do not have a tube in place by then, we'll back out and go back to BVM. Get our 3-minute timer started over.
And as you guys just observed, if you have a drop SAT, you must bail out and reoxygenate for another 3 minutes before reattempting intubation. Let's now look at the intubation process.
Let's leave the high flow nasal cannula in place.
As you guys just heard, leave the nasal cannula in place at flush rate during the intubation to extend the time to desaturation.
Feel?
If our pre-oxygenation was successful, the intubation attempt will be extended without hypoxia because we did a good job of washing all of that nitrogen out. This will allow us to perform our techniques in a smooth, unrushed fashion. We also have that added insurance that we have someone watching the monitor, remember the monitor watcher, to keep us out of the red with our oxygen saturations.
Bougie in.
And just to highlight the amazing job that the airway assistant is doing in the demonstration, this is the proper technique for introducing a tube with use of a bougie. We rely on our airway assistant and the medic maintains control of the tube.
Inflating up. Attachment in. Give a breath.
We have good end title.
Can you grab the stethoscope for me, Brandon? Play the kit though.
The crew will now complete their intubation by securing the airway, and they will prepare for post-intubation management. And just because it bears repeating, make sure that you use your checklist and complete it as a team, going all the way through the end of the post-intubation management goals. To keep things simple, we will use ketamine as our post-intubation management agent. The benefits there are that it is a dissociative and therefore provides pain management as well as sedation.
And I'm going to draw up ketamine.
Administer ketamine to a goal RASS score of -5, meaning not arousable. To achieve that, we have two options. Option 1, a repeat bolus dose, also known as our pre-ox dose, of ketamine at 2 milligrams per kilogram, IV or IO. And remember, guys, from the post-invasive airway management protocol that we want to give this dose immediately after securing the airway. And the goal here is to give the patient some form of sedative every 15 minutes for the rest of the duration while we have contact with them. Or we can give a ketamine infusion starting at 1 milligram a minute and titrating up by 1 milligram a minute to reach our target RASS score. Mixing instructions for that are standardized. We will mix 200 milligrams and 100 milliliters normal saline, which gives us 2 milligrams per milliliter of normal saline. Math on that is pretty straightforward. We come out to 0.5 milliliters a minute for administering 1 milligram a minute, and we will titrate that up to our target Richmond agitation sedation score of -5 and hold it there. This should be placed on a pump if you choose this option. However, we do recognize that the pump could be occupied being a single channel with other medications like vasopressors. So you can use a dial-a-flow to achieve this, and it's basically multiples of 30 mils a minute to give your dosing, so 30, 60, 90, and that'll be 1, 2, 3 milligrams per minute, so on and so forth. The team will now prepare for transport and will ensure that the patient maintains a end-tidal CO2 reading between 3.5 and 4.5 unless there is some special physiologic situation occurring that requires modification of that, and will monitor the patient's RASS scores until they reach the emergency department.